The following presentation takes a look at complex post-traumatic stress disorder and will be referred to throughout as complex PTSD. I'll begin by looking at a brief case study that will be referred to throughout the presentation just to reinforce main points and to explore how I would consider working with an individual with complex PTSD. We'll take a brief look at what is trauma before focusing on the central concepts of PTSD, the populations predisposed to complex PTSD, the implications for counselling, how we would treat complex PTSD, focusing on goals, an approach to treatment, and a review of some treatment interventions. And finally, we look at the prognosis and the importance of counsellor self-care. So the case study chosen is Susan, a 27-year-old married Asian woman who was reported being sexually, physically and verbally abused by her father between the ages of 5 to 16. She actually disclosed the abuse to her mum at age 8, however it continued. And because of her disclosure and outcry, her parents blamed her for disrupting the family. At 13, her parents divorced, but the abuse continued during the weekend visits with her dad. At 16, Susan moved in with her grandmother and the abuse ceased. So during high school and college, Susan had problems regulating her emotions and experienced flashbacks of the abuse. She also reports significant memory gaps, and in college she discovered that she had been involved in relationships she could not remember. Furthermore, friends and family members noted times she acted differently, unlike her normal self and being different Susans. These revelations added to stress to Susan's marriage and to her fears of abandonment. She also reports hearing voices in her head since childhood, but Susan has not engaged in self-harm or had any thoughts of suicide. So what is trauma? Trauma is an individual's experience of or exposure to a difficult and overwhelming event. Exposure can either be witnessing or hearing about a family or friend who has experienced a traumatic event. The event may be actual or threatened death, serious injury, which could be violent or accidental, or sexual violence. Symptoms can manifest immediately or later on, and they tend to be physical, emotional, cognitive, or behavioral in nature. Everyone's reaction to traumatic experiences is different, and it is actually normal to respond to a traumatic event, and dealing with the symptoms whilst distressing is actually all part of the healing process. However, for up to 30% of individuals, these symptoms can be severe and or last a long time. And when they struggle to cope, they develop serious conditions that require professional help. And one of these conditions is complex PTSD. So what is complex PTSD? Well, it isn't actually listed in the DSM-5, but due to the severe psychological harm caused, the World Health Organization has included complex PTSD in the International Classification of Diseases 11th edition. There is actually a call for the classification of trauma-related disorders to be included in the DSM-5 and arranged on a continuum of symptom severity. So the central concepts of complex PTSD. Complex PTSD shares the same diagnostic criteria as PTSD, plus an additional 4 domains. So the PTSD core symptoms are hypervigilance. People are often easily startled and appear to be on edge. Avoidance. They can avoid memories and situations that remind them of the event. Re-experiencing, which can include flashbacks and nightmares. So the additional domains include interpersonal disturbances, and this can be kind of a negative belief system of themselves and the world as an unsafe place, and they can be prone to personality change and hearing voices. So interpersonal difficulties, they often struggle with interpersonal relationships, to the point sometimes where they become socially isolated. affect regulation. These individuals have problems regulating their emotions and can experience mood swings, dissociation, and engage in self-destructive behaviours. Impairment in all aspects of life. It can affect them personally, their family interaction, and have an impact on their education and their working. So PTSD tends to respond. PTSD tends to occur in response to a single event, and individuals tend to respond well to short-term counselling and sometimes drug therapy. And in contrast, complex PTSD occurs in response to repeated and extreme events over a prolonged period of time. It tends to be generally more often than not interpersonal in nature and related to childhood experience, but this isn't always the case. And individuals tend to experience fear, helplessness, and entrapment. Hence, longer-term therapy is needed for complex PTSD. So in Susan's case, it is clear that she has experienced repeated and extreme events over a prolonged period of time, and she reported symptoms of an intrapersonal disturbances, interpersonal difficulties, and emotional regulation difficulties. And this tends to indicate that she is actually suffering from complex PTSD. So here's a list of the populations predisposed to complex PTSD. And again, if we refer to Susan's case, not only has she been a victim of chronic abuse, the abuse occurred during her childhood, and she also was neglected by her mum, who failed to protect her. So implications for counselling. So there is the risk when working with this population to actually misdiagnose, given the comorbidity of many conditions such as anxiety, depression, and social phobia. But we need to make sure that we view these as symptoms of complex PTSD and not standalone mental health issues. Borderline personality is a tricky one because symptoms do overlap between complex PTSD and BPD, particularly as trauma decontextualized over time can look like personality disorder. And some argue that a change in personality is inevitable given the severe psychological harm that is caused. However, the main difference is that those with complex PTSD tend not to oscillate between positive and negative self-belief, whereas they do with BPD. So hypervigilance, one way to kind of cope with this is to make sure we're always working within the client's window of tolerance, and there is a high risk of re-traumatization. So we need to always make sure that we work ethically to avoid causing psychological harm. So attachment issues is not unusual, particularly if the trauma was at the hands of the caregiver, to suffer attachment issues. And in Susan's case, she seems to be displaying disorganized attachment, which means that she might become overly dependent on the counsellor. So we just always need to make sure that we reinforce and maintain healthy boundaries. So to counteract the client's low self-esteem and loss of agency and control, a strengths-based approach to treatment is recommended. So these individuals tend to have difficulties sustaining relationships, and as we mentioned, experience mood swings, which can lead to them oscillating between an obliging or an avoidance stance with a counsellor. There's a large element of mistrust, and one of the best ways to work with this is to adopt the trauma care principles. So we need to focus on safety, trust, choice, collaboration, and empowerment. So when establishing the therapeutic relationship, we need to recognize that building trust will take time. We need to go slow. Always reinforce the confidentiality aspect to ensure them that they are in a safe space. Provide a voice and a choice, i.e. consider their needs and preferences, Always explain what we are doing, seek permission, ensure we're operating in a culturally appropriate way, and be willing to hold space for the individual, and always normalize, validate, and display empathy. So treatment tends to take time when working with this group. And, when clients present, they're experiencing extremely distressing symptoms. So we need to help them manage and cope with these symptoms from the outset. So the goals of therapy. So as just mentioned, the first goal is to help them gain relief from their distressing symptoms, and then work to build their self-esteem and empower the client so that they can move forward and improve their daily functioning. But above all, we must always remember to avoid re-traumatizing. So treating complex PTSD. We need to work with the mind and body to help the client achieve stability and growth. Use a strengths-based approach to help empower the client, and used evidence-based interventions to address their trauma. So approach to treatment. The power threat meaning framework provides an alternative to diagnosis. And whilst diagnosis can provide relief and reassurance for some people, and is sometimes necessary for funding services, identifying what is wrong with the client and focusing on their perceived deficits can only add to their low self-esteem. So what we need to do within this framework, symptoms are considered threat responses, i.e. voluntary or involuntary coping strategies. It's actually an approach that complements other interventions and can be used provided the client can self-regulate. The power threat meaning framework provides a lens to understand the client and the impact their systems are having on their lives by identifying what has happened to them and the sense they made of the power that was operating in their life at the time. So the PTMF can be considered culturally appropriate when working with Susan, as it avoids labelling her and hence avoids the shame and stigma associated with mental health issues in collectivist cultures. There are 3 phrases recommended when working with trauma. So phase 1 is concerned with safety and stabilization. Phase 2, we look at the trauma processing. And phase 3 is reconnection and reintegration. So phase 1. So we always need to make sure that we prioritize any addictive or self-destructive behaviors, and make sure we're working within the client's window of tolerance by providing grounding and self-soothing techniques. Psychoeducation can be used in this phase to help normalize and validate the client's responses. And it's important here to help the client recognize when they are safe but triggered. Those with comorbid conditions may need to take longer in this phase. So if we consider Susan, she's not actually reported any addictive or self-destructive behaviours, but assessment would capture these. And I believe that Susan would benefit from psychoeducation to help her raise awareness to and understand her symptoms of trauma, how they have helped her survive but are no longer serving her well. We can actually teach strategies to help her regulate her emotions and address the hearing of voices. Recommending a support group for Susan will help to further normalise and validate her problems. Journaling would be another technique to help her cope with the current distressing symptoms and to track symptoms between sessions so that she can communicate these with the counsellor at the next session. So trauma processing. So this is where the evidence-based interventions come in, and there are several to choose from. So there's eye movement desensitization and reprocessing, EMDR. and that is recognised by the World Health Organization as the gold standard, particularly when working with adults. So with the EMDR, the client briefly focuses on their traumatic memory while simultaneously experiencing bilateral stimulation, typically eye movements. It's a relatively short treatment, hence considered cost-effective, and it offers the client the ability to process trauma without actually having to talk about it. However, we must remember that it's not suitable for individuals with vertigo or epilepsy, or those in unsafe relationships. So trauma-focused CBT looks at behavioural and or cognitive strategies to target the impact of the trauma. It's actually the most empirically supported intervention when working with children and adolescents, and it's quite structured in nature. However, it can be considered slightly inflexible, so it may not meet everybody's needs, which can lead to individuals feeling disconnected and frustrated. Imagery rescripting, IR. It's a technique to alleviate the traumatic memories by helping the client imagine a more favourable ending to their experience where their core needs at the time are met. It can be a standalone, brief intervention, or it can be integrated into regular work. It requires limited exposure to traumatic memories, and actually working with just one memory can be sufficient. Research is limited at the moment, but those studies that are available suggest it's equally as effective as EMDR when working with trauma stemming from childhood. However, 90-minute sessions are recommended, and this can be an issue when funding is limited to 60 minutes. And the shorter the session, it leaves little time for debriefing, and then the client can be left feeling quite distressed. A lack of trust in the therapist could actually mean that some individuals struggle to engage with IR. So dialectical behaviour therapy. This approach actually works to increase distress tolerance and emotional regulation skills, to then work on symptoms such as intrusions, self-esteem deficiency, and interpersonal relations. Over 40 sessions are recommended for this treatment over a period of 3 to 12 months. And it does actually neglect the negative thoughts and emotions that these individuals often have, such as guilt and shame. And again, it's quite limited research when it's compared with other treatments. So narrative exposure therapy. The individual narrates their past traumatic experience and relives their emotions and senses experienced whilst remaining connected to the present. This approach can actually work well with refugees and First Nations people, and it is a short-term focused treatment. However, again, there's limited research comparing with other treatments. So when working with Susan, I would suggest a trauma-focused CBT because of its evidence-based and structured approach, which tends to be favoured by individuals from collectivist cultures, and maybe integrate IR, given that her trauma stems from her childhood and she is hearing voices. However, I would also talk with Susan about EMDR as an option and offer her the choice. So phase 3 are reconnection and reintegration. So if the decision has been made to work with PTMF, we can revisit it at this stage, and then we move to see how the power is sitting in their lives now, and then we move the focus to the future. So the client is empowered by this stage, given they now understand their trauma responses, which will help eliminate any self-blame and shame they may be experiencing. They can recognize their triggers, and they will have developed coping skills and strategies, so they can move forward and live life with appropriate boundaries, levels of trust, and emotional regulation. And it's important to remember that we can revisit phase 1, which is the safety and stabilization phase, whenever necessary throughout the whole treatment plan. So whilst complex PTSD is a challenging condition to live with and treat, with time, a trauma-informed approach to treatment and trauma-focused interventions, positive outcomes can be achieved. So finally, I just wanted to highlight that working with this population puts us at more risk of compassion fatigue, vicarious trauma, and burnout. So we always need to make sure that we're taking care of ourselves, receive adequate training and support, and to recognise what we're not equipped to deal with. Thank you for listening.